All right. Good morning, everyone. My name is Pilar Marrero, and I am a journalist, a writer, and an immigrant living in the Los Angeles area for more than 30 years now. Thank you so much for joining today for the Venice Family Clinic's Health and Justice series. This series was created to have a forum to discuss all the ways that health intersects in our society, with our society, and why it's critical that we understand the issues and often the injustice that stands in the way of everyone having access to healthcare. Venice Family Clinic provides primary health care to people in need through medical care, mental health care, substance use treatment, and many other services. So before we start, I want to mention that there is a Q&A function at the bottom of your Zoom window. Questions regarding our presentation will be answered live at the end of the panel. So you can put your questions there in that Q&A function at the bottom of your window. Additionally, there is also information about how you can make a donation to support the work of Venice Family Clinic. Okay, so now allow me to introduce our very distinguished panel today for this discussion. First, I'm going to introduce Dr. David Carlisle. He's president and CEO of Charles R. University of Medicine and Science in the Watts Willowbrook area of LA County. He is an expert in health policy, medical education diversity, and eliminating health disparities. Welcome, Dr. Carlisle. Then we have Dr. David Hayes-Bautista. He is the director of the Center for the Study of Latino Health and Culture at the David Geffen School of Medicine at UCLA. His research is focused on culture, behavior, and health. Hello, doctor. Welcome. And then we have Dr. Margarita Loeza. She is a family physician and chief medical information officer at the Venice Family Clinic. In addition to serving as a volunteer physician for UCLA, Flying Samaritans, and Homeboy Industries, and a mentor to Latino students in medicine through the Alliance in Mentorship. It's an honor to have all of you to discuss such an important issue. Our topic today is racism as a public health crisis. And we will start where we are today. We are in the middle of a pandemic. I think everyone's aware of that. And the numbers and the rates in which certain groups get infected and die of COVID-19 are different for different populations. So I'm going to go first to Dr. Hayes-Bautista and ask the doctor to explain to us what do the numbers say about the rates of COVID infection by race and by population?
Well, whether we're looking at cases per 100,000 or deaths, what the data tell us is that Latino, Black, Asian, Native American, Alaska Native, Native Hawaiian, Pacific Islander, that's about 62% of the state's population, have far higher rates of either cases, infection, or of deaths, ranging from half again as high to 5 times as high. The question is why? And we have to remember that the coronavirus does not discriminate. The coronavirus is not racist. People are. People discriminate. People make decisions, provide service to some communities, deny services to other. What the coronavirus does is expose these fault lines. Who has had access to services? Who has been denied services? Who has to work without a health insurance, without personal protective equipment? Who gets to shelter at home and telecommute to the office? And it's just exposed these cesspools, this discrimination that's part of this racially structured society. COVID has laid it out there in plain colors. Those are the ones who get sick. Those are the ones who die. And yet those are the ones who make this economy work.
Thank you, doctor. So I'm going to move to Dr. Carlisle because I want you to give us a little bit of background of what history tells us is the intersection between racism and medicine, because this is not a new story, is it, doctor?
No, and thank you very much. It's a pleasure to be here. And no, racism is not new in medicine. In fact, as with almost every aspect of American society, racism has been here with us from the start. I'm sure that if we were able to identify good evidence, we would know that slaves did not have great health care. Life expectancy was probably an issue. If you were old and decrepit as a slave, you were a mouth to feed and nothing else. Your life expectancy was not expected to be great under those circumstances. If you go on to Reconstruction and the end of Reconstruction, the Flexner Report. The Flexner Report, credited with giving us the medical education system that we have today, which is excellent, closed 9 of 11 historically Black African-American medical schools. We could definitely use those doctors today. If you fast forward to, when I was a little kid, when my wife was a little kid, she was first thinking about applying to medical school. And I'll say Jim Crow was there waiting for her. Because when she looked at medical schools to send applications to, a number of them told her, don't waste your time. We do not accept Black students at our medical schools. And of course, as we move forward into the end of the 20th century, it became quite clear that the anecdotal information that we had about disparities in healthcare and healthcare outcomes was confirmed by data report after data report after data report. Everywhere you look, there are disparities in outcomes, disparities in treatment, disparities in access. This defines the American healthcare system. I was lucky one day to be reading a novel from the Harlem Renaissance, the 1920s. Entirely different subject, but I was shocked when I came upon a passage where the main character was offered by a white physician to come in and be seen in a clinic. And the main character said, no, I will wait for the Black physician. Even in the 1920s, awareness of disparities in care and treatment was commonplace in the African-American population.
Thank you, doctor. So coming back to today, Dr. Loeza, I'm going to bring you into the conversation. Dr. Hayes-Bautista was mentioning a little bit about the causes of these disparities and these health outcomes that are different for different groups. How does the workplace influence these rates? Because I was recently at a conference with Dr. Barbara Ferrer. She's the public health director of the county. And at the beginning, they did not catch the difference between the rates in people who were actually the essential workers and people who were not. So it was a sort of a surprise for everyone that those were the people that had the highest rate. So can you talk to us a little bit about that?
Well, our essential workers are usually people that work in grocery stores, food service, that can't do their work from home. So they can't do telework. They have to be in the workplace. And as the pandemic rolled out, we didn't know enough about it and we weren't ready for it. So a lot of the workplaces didn't have personal protective equipment. They didn't have screening tools or temperature checks or, require people to wear masks. And it's usually people of color, people that are poor that have these jobs and they're at increased risk for getting COVID. So they have to go to work. They can't miss a paycheck. A lot of them also don't have free and accessible testing near them or the right information so that they can protect themselves, or if they're sick, they can go somewhere to get help and then they bring it home. So if you can work from home, you can stay safe. But if you have to go to work and the people that are coming into your store refuse to wear masks or aren't, staying 6 feet apart, it's really the most vulnerable are the essential workers, are the ones that have to show up. And they're also the people that live paycheck to paycheck, have lower income. A lot of our undocumented patients don't have workers' comp benefits or holiday time, or, and a lot of people don't have internet at home. They don't have a hotspot or a way. So they're vulnerable. They have to leave the house. And if they don't go to work, they can't pay their rent, and then they can lose their insurance or end up homeless. So it's just like, I think that's why we're seeing what we're seeing now. And it is the root cause of all this is racism too.
All right, so one of the issues in the spread of this pandemic has been the lack of enough testing across the country, right? And the disparities in where you can find testing or not. Different states have different capacities, et cetera. So what about COVID-19 testing accessibility in low-income communities? And this question is for any of you who wants to answer or to have a conversation. Are we seeing now adequate access and affordable access to this testing in these communities? Anyone that wants to
I
go
think
ahead.
Charles Drew has done a great job testing, having free testing on site from the very beginning. I think Dr. Carlisle can speak to what he's done for that community in SPA 6, which is, Venice Family Clinic is in the service planning area 5, but the free and accessible testing at Charles Drew has been really great.
Yes, thank you, Dr. Loeza, for that, and thank you for the recognition. Because of I think the vision of LA County Supervisor Mark Ridley-Thomas in collaboration with the LA County Fire Department, as well as the County Department of Health Services, we were able to basically bring COVID-19 testing, the first county testing site, to South Los Angeles. Within a few weeks, we'd gone beyond 200 and some individuals per day to our capacity of 450. Eventually, we got to almost 1,200 tests per day. And we were able to do this because we recognized that in our under-resourced community, simply operating drive-through testing doesn't cut it. One of the resources that are under-resourced in our community is simply having a car. So if you're depending on people to drive through to get COVID-19 testing, it's not going to work. We started inviting people to walk up. And then we started inviting people to come in who didn't have appointments because, as you mentioned, lots of people don't have access to the internet. They can't go online and make an appointment. Once we did that and started marketing our services in shopping centers and on the street, and especially mentioning the fact that it was free, gratis, people started coming. So if you want to get tested, if you want to reach a population like the one we serve, you can't just rely on drive-through. You got to mention it's free. You got to make it available to the person on the street who may not have an internet access. And then you can triple your access to COVID-19 testing. We rapidly learned that COVID-19 is not a disease of the affluent. It's not a disease of Hollywood actors. It's not a disease of international travelers. It's not a disease of professional athletes. It is a disease that is particularly afflicting populations of color that are providing essential services to urban inner city populations. And that's where the focus is. And we learned that through COVID-19 testing.
And I would like to just chat about the other side where there weren't sufficient efforts made. In fact, going back to the first weeks of the pandemic in early March, I remember the Los Angeles Times called COVID a rich man's disease because the cases seem to be concentrated in the Platinum Triangle, Beverly Hills, Bel Air, Brentwood. And of course, they got testing immediately. Remember, the Lakers got tested within hours.
Right.
If you have access to boutique medicine where you're paying a physician $5,000 just for retainer, you got to get early access to testing. Now, remember that, in fact, for about the first 2 months, you needed to have a doctor's permission to even go get a test. Well, in the West Side, that's not a problem. So the orders came to shelter in place, people in the West Side working the types of jobs they could take their computers home, their kids got out of school, did their lessons online, everything is fine. But once a week, they had to go to the grocery store. And you remember how people were fighting over paper towels and toilet paper? People didn't understand that they weren't fighting over food, say the last sack of potatoes, because farm workers right out here in Ventura County, in Kern County, every day were exposing themselves to the virus, working in large crews. They were provided no personal protective equipment. Farm workers are almost exclusively immigrant Latinos, very large percent undocumented, very low wage, no health insurance being offered, have no connection to a physician. So even if them wanted to, and understands that if you're charged at private rate, a test could cost as much as $2,000 and you're making maybe $800. You don't have access to a physician. how are you going to get tested? So many of them didn't. And as we've seen, as the COVID has spread in the workers, the packing house workers, gardeners, construction, bus drivers, grocery store clerks, et cetera, they had to wait until they were extremely ill, then walk into the ER with a very advanced case of an illness caused by COVID infection. That took up until April for them to start to show up. So it seemed as if Latinos in particular were a second wave. I kept saying, no, they're part of the first wave. They didn't have access to get noticed until late April, early May. So now we say, well, we'd like to have more testing, but we don't have enough locations. There's not enough outreach, that's for sure. Our testing efforts as a state are not very good. Our testing efforts as a nation are abominable. The idea that if you don't test, you don't know how many people are sick, so you don't have a problem. So I guess it's like if you don't check your heart rate, you don't know that you're having a congestive heart failure. So we don't have a problem with congestive heart failure, but we do. Sticking your head in the sand is not good medical practice when we have a pandemic such as we do. So thanks to the community clinics, thanks to centers such as Drew, clinics like Venice, there are actually sites for the farm workers, for the packing house workers, for the grocery store workers to go and get tested and seek care.
Yeah, that's true. I spoke to some farm workers over the last few months, and one of the issues is that even if they get protective equipment in the workplace, which some did, some who were unionized did, very few, they travel together in these trucks, you know, to go back and forth from home to the fields. But anyway, let's move on. So all of this is happening in the context of a larger issue in the United States, which is access to healthcare, right? We have a very expensive healthcare that, you know, this country spends more than anyone else in healthcare. And we still have many people who are uninsured and underinsured. So what role has this played, in your opinion, this goes to the three of you, in how the pandemic has played out in the United States? Because we heard a lot from Europe, for example, where, you know, in Spain, in Italy, in all these countries, where people have more of a universal health net or healthy net, that was working. So we don't have it here. What's the effect of that?
Well, this is what
go ahead. Go ahead.
Dr. Loeza.
No, it's okay.
I was going to say, and pardon me, this is what I like to call the final wave of COVID-19. You know, maybe you just barely escaped with your life. You were in the hospital, and for weeks in the ICU, you don't even have a memory of that. And you're home, you're better, and then the final wave hits. You get a bill. And that bill might be for over $100,000 for medical care. And your insurance, if you're lucky enough, may not cover that bill or large parts of it. What do? This is not just a COVID-19 phenomenon. This is American healthcare. You're at home, you're short of breath, you have a fever. You're going, well, do I really need to go to the emergency room? Because I can't afford to pay for the emergency room. You stay at home. And as we know with COVID-19, you can often die suddenly under those circumstances. This is American medicine. It is inhumane, it is unjust, but it defines healthcare in our country as the only industrialized nation in the world where this is true. And this is a problem for us. And COVID-19 is just the latest manifest. And yes, that final wave from COVID-19 is around the corner. It is lurking for individuals, and it is preventing them from getting healthcare.
Anyone else wants to chime in?
Dr. Loeza.
Well, I was just thinking about, you know, what Dr. Carlisle said, and what we're facing right now is that healthcare is a human right, but we treat it as a business and a commodity for the rich. And so as long as that remains the case, the poor will suffer and the poor will die from COVID. And it's not just. And, you know, we haven't even touched upon like the mistrust that Black and Latinos have for the healthcare system as a result of years of, racism, injustice, and bias, and the lack of physicians of color. And I know that Dr. Hayes has studied that, has showed how there's less Latino physicians nowadays. And I know that Dr. Carlisle has been working to increase the number of physicians of color. But I mean, that's another thing, that when I speak to patients, that they tell me they didn't understand the physician, they didn't speak Spanish, they weren't treated poorly, they were just let go, they were ignored because they didn't have insurance, or they went to the wrong hospital because and so it goes very deep. And I think because of the way the system is now, when we get a pandemic, we're going to see people of color and the poor bear the burden of the disease.
So let's go into that issue. Let's go into, yes.
Pilar, could I just
Yes.
extend a little at something Dr. Loeza said about the physician shortage, because that's something we've been studying in great detail.
I was going to that.
Okay.
Go ahead.
The Latino physician shortage is so huge that at the current rate that all California medical schools, public and private, graduate Latino physicians, it will take 500 years to make up the shortage for right now. So just imagine you're Senora Gomez and you suddenly feel, oh, I've got a temperature. I've got this cough in the back of my throat. I need to go see a doctor. So she runs over and says, I need to see the doctor. Oh, yes, Senora Gomez, please take a seat, and the doctor will see you in 500 years. So COVID says, oh boy, I love this place. And even worse if she's trying to find a Spanish-speaking doctor. And of course, people say, oh, but this is California. You don't need Spanish-speaking doctors. Medical services have been provided in Spanish in California every single day for 251 years. Mm-hmm. This is California. We do this, and we do it in other languages as well. We've done that for over a century in many, many other languages. That's California. Everybody should be able to access services in the language that they're most comfortable with, because that is the history of California.
Okay, so Dr. Carlisle, can you explain to us why it is important to have doctors, nurses, and other health professionals of color? Is it just because, oh, I just want a Latino because I feel more comfortable, or there's actual data that says the outcomes are different?
Well, there is data. And just recently, a study was published that basically said, if Black babies are cared for by African-American pediatricians, their likelihood of experiencing infant mortality drops by 50%. This is just the latest study. AIDS, HIV, when I was a fellow, the late Dr. William Cunningham published a study basically saying that quality of care for HIV patients improves if there is concordance between physician and patient ethnicity. But let me skip some of the data and go to a personal anecdote. So here I am, I'm a patient at UCLA in the outpatient center, but I'm primarily a faculty researcher. And one of my patients comes up to me, and I see him regularly. He's a senior faculty member at UCLA, full professor, tenured, department chair. And he says, Dave, do you ever wonder why I chose you to be my doctor? And I say, well, yeah, I'm not going to show up and see you in the emergency room. I'm not going to come and greet you in clinic if you don't have an appointment. I'm going to be doing my research. My colleagues are going to. So yeah, why did you choose me? And he said, well, when push comes to shove, if push comes to shove, and I am in the ICU in a coma, and somebody has to make a critical decision about my care, I feel like I can trust you more than your colleagues to make that decision. Why? Because you are Black and you're the only African-American physician at that time in that division at UCLA. And I am also African-American, and I trust you. And this is a person who has everything going for him, all the power in the world at UCLA, and still concordance and trust is a major issue for him.
That's incredible. So, okay, Dr. Loeza, you have been working on this issue as well to mentor students of color. And I think you are also collaborating with Dr. Carlisle in some initiatives. Can you tell us a little bit about that?
So I'm part of Alliance and Mentorship, which is a group of physicians that sponsors Mi Mentor, so it's MI Mentor, and we have 10,000 members, and we have an app, and we put on many programs, Dr. Talamantes and Montes, and we started this, I feel we started this about 7 years ago, along with a lot of other Latino doctors. And so what we do is we mentor pre-health students, and we help them through the med school application process. We mentor them by reading their personal statement. We help them get letters of recommendation. We even go so far as helping them with their headshot to make sure that their application looks great. And I'm lucky enough right now that I've been on the Charles Drew Medical School Admission Committee for the last few years. And I've also been on the David Geffen School of Medicine Admissions Committee. And so I also have been doing that so that I can pick and, physicians that I think will work in my community, that would work at Venice Family Clinic, that have a social justice lens, that speak more than one language, that identify with the struggles of the patients that we see. So what we do is by letting students see people like us or people like them, because they need to see Latino physicians, they need to see, we need to have pipeline programs. And when I was younger, I went to Charles Drew University for a summer MCAT program, and they gave me money, and I took the MCAT once, and I got into medical school. When I was younger, I used to go to, Latino medical student conferences, and I would see Dr. Hayes speak. So I'm a product of those pipeline programs. And so I've been working to continue that pipeline and to mentor. And I still have some students tell me, you're the first Latina physician I've ever seen. And that's just, it's still like, I still can't believe that sometimes. And so I think that you need to see someone like you succeed, and so that the dream becomes believable. And it's incredibly difficult to get into medical school and expensive. And our students are very poor, and they're first generation students. So their parents haven't gone to school. So they don't know how to navigate the system. So there's a lot of barriers just to get in. And then once they stay in, they still have more barriers. So we try to help them through that.
Thank you. Thank you so much. I think we're all very eagerly awaiting the vaccines and the treatments for COVID-19. I mean, we already know there are treatments that are working, and there's several vaccines coming up. But I wonder about the access issue in regards to this. Are there plans in place that you have seen, that you've heard, that you've been part of, to make these treatments and these vaccines available? Because if we don't make them available to these essential workers and to these teachers and to, people who are going to be out there, what good will it do? Anyone?
I think the vaccines, hopefully, we get the vaccine. When we do, we'll have to find a way to give it to everyone. In addition, it's the same problem right now with the flu vaccine, right? So how are you going to get your flu vaccine? We'll have to come up with processes for that. And I think that, our clinic has worked really hard to reach out to our patients and let them know it's time for the flu vaccine. Come in and get your appointment. So, but we have to make it available at the pharmacy for free, at your church, at schools. Maybe when you get a COVID test, you can get a vaccine at the same time. We'll just have to work out something. It'll be hard, but first we have to get the COVID vaccine. And I hope people will accept it.
And I have to say, as I was originally trained as an engineer. So when you start a project, you need to know exactly what's going to happen. Part of the problem is we do not have any plan at the national level. Once there maybe is a vaccine, how is it going to be distributed? We have no plan.
Right.
Absolutely none. So unfortunately, clinics such as Venice or others, let's see what we can do.
Right.
That's not the way you do things at a larger scale, but we do not have a plan at the national level. I have heard some chat about the need for one at the state level, but right now it's devolving down to the local county, city, community organization, which is going to be a very, very haphazard way to do things.
And we know that if you rely on that kind of ad hoc distribution system, it's like the advent of COVID-19 testing. Mm-hmm. Guess who's going to get it first? As Dr. Hayes-Bautista said, the platinum triangle. is probably going to get the first crack at access. People can buy the vaccine are probably going to get the first crack at access. People with great access to healthcare are going to get the first crack at vaccination access. If we want to be effective in making sure that vaccination efforts work, we need to turn things diametrically around to make sure the most vulnerable communities, communities of color, are getting first access to that vaccine, including healthcare workers as well. Because otherwise, if we just let things unfold naturally, it'll be COVID-19 testing all over again.
This is very important. I haven't heard a lot of talk about this at all out there in the media. So
As
that's a note for me.
As Cantinflas would have said, you haven't heard anything. Ahí está el detalle.
Ahí está el
There's the
detalle,
detail.
señor.
Yeah, I've heard nothing. That says a lot.
Mhm,
We don't have good leadership at the top, so we have to do what we can.
And speaking about that, not that we can forget this, but we have an election in 2 months.
Yes.
So I want all of you to chime in. What does this country need in terms of healthcare? What's your wish list in terms, and what's your take on current platforms, if you can call them that, of the main presidential candidates?
Well, when I've been doing media work about COVID, and people finally ask, well, so what's the long-term solution? And I tell them the long-term solution is simple, it's easy, and as Dr. Carlisle said, every other country we compete with has already done it. Japan, Germany, Italy, UK, you name it, they all have universal access to healthcare services. You can do it through National Health Service, you can do it through insurance, there are all kinds of ways to do it. Everybody knows they're going to get access to care. As a result, they spend half of what the United States spends. However you want to denominate it as percent of GDP, we spend 18% of our GDP on healthcare. They're spending 8, 9, 10%. We spend close to $15,000 per person. They spend about $7,000 or $8,000. And their indices from infant mortality, the highest. In the ranking, world ranking, US ranks around about Bulgaria for things like infant mortality, yet we're spending the most. So why can't we do whatever? Let's be healthier, spend less, let's get universal access. But that has become a politicized issue since the 1930s, actually since Fleckner in 1910, has been heavily politicized. We have a fetish about free market and healthcare, and yet healthcare is not a free market like refrigerators and cars, where the buyer and seller know equally as much. When it's healthcare, the consumer has no way of knowing what the provider knows. So we've entrusted things to a free market, and this is not something we should give to a free market. It should be like water, like air, like education, a human right, which every other country that we compete with has already done.
And if I just have to say, and I know this is the same for all of us on this panel, for me, for us, it's personal. My family, I have family members growing up in Compton, living in South Central. When you can't get access to healthcare, it's personal. Getting care at county hospitals, it's personal. The disparities that exist are intolerable when you view it from an international perspective. This is a personal issue. We talked about why our COVID-19 testing was so successful at CDU, and there's a report on our website about this. But one thing that I didn't mention is the fact that people come to the site and they see providers and students who look like them and speak like them. That is tremendously reassuring to the patient population. That's important, and it's part of what we need to have happen. I just want to comment on a vignette that I saw on the web, and it is telling along the lines that Dr. Hayes-Bautista was speaking. This is a woman from Taiwan. COVID-19 is broken out. She's living in Great Britain with her boyfriend, universal health insurance in Great Britain, but she's making a difficult decision. She decides to leave her boyfriend in Britain and return to Taiwan. And her comment is telling, and it speaks to this. She said, I decided to leave my boyfriend in Britain to go back to Taiwan because I know that in Taiwan, my government will care for me. If I get sick with COVID-19, they will protect me, and they will do everything they can to make sure I have a good outcome. That is just the exact opposite of healthcare in this country. It is very unfortunate that that is true. I'll close by saying, you know, I don't know if everyone saw this, but in this morning's LA Times, there is an editorial, not an op-ed, an editorial. And it is talking about the president's new COVID-19 director and this approach that is being considered by the administration to achieve herd immunity in the United States. And the editor of the LA Times is saying, do they really realize what that means? Not that it's worked anywhere. It hasn't worked in Sweden, didn't work in Italy, et cetera, et cetera. If we try to pursue herd immunity as a solution for COVID-19, hundreds of thousands, millions of Americans will probably die as a result. And disproportionately, those will be individuals of color. How can we have a healthcare agenda, a policy that even contemplates the heinous thought of herd immunity as a solution to COVID-19? I just say it rests with our current administration, and I will say nothing further. Read the editorial, LA Times this morning.
Okay, thank you, doctors. We're going to go ahead and go to questions. We have a lot of questions and very good ones at that for the last 20 minutes of our chat. Okay, so we have a question here that talks about testing people without symptoms. Says, we know that people without symptoms can have and spread COVID, but the county is still only testing people with symptoms. Other counties across the nation are offering testing to anyone, regardless of symptoms. Should LA County start doing the same? Is this true?
I can't speak to LA County policy. I know that during the peak of our on-campus COVID-19 testing, testing was available to anyone. You could walk up. I will say, however, that I know that this has garnered a lot of attention from the Centers of Disease Control recently. And as a public health person, this is the exact opposite of what you want to do to control a pandemic. The people who are most vulnerable are people who are exposed to people who are asymptomatic. If you're designing a virus that doesn't discriminate, you make that virus transmissible from people who are asymptomatic. If we're going to control this pandemic, we absolutely have to test people who are asymptomatic. No ifs, ands, or buts about it. I can't understand the motivation for this policy coming out of the CDC because it's the exact opposite of what you need to do to control a pandemic. You want to control syphilis, you test. You want to control HIV/AIDS, you test. Testing is critically important. And I think that we need to make sure that it's part of our pandemic control policy going forward.
And part of that also just depends on something as simple as logistics. Are there sufficient test kits around? Do you have sufficient personnel to deliver them? Just about 3.5 weeks ago, we've been having, we had an upsurge again. The first part of the first surge didn't quite fill the hospitals in LA County the way they did in New York. And I remember towards the end of April, even some hospitals were discussing, well, should we close our COVID unit? We only got to 60% capacity. Did we dodge the bullet? And then suddenly in came May and June, suddenly they started to fill up again. And just about 3.5 weeks ago, I was talking with the COO of a hospital here in Los Angeles County, and it was Friday evening. And this topic came up in one of our more recent COVID reports out of the center. And so we got to talk about testing, and the COO was kind of hinting there. They didn't have a lot of tests. So finally I said, look, tell me outright, how many tests do you have available? And this is Friday night. She said, right now I have 40 in the middle of Los Angeles County. Duh. And that's a logistics issue. And again, that goes back to, we have no national plan, nothing. Absolutely nothing. And we're getting down to where a major hospital had only 40 tests available and the weekend was starting. That's what happens when we do not have good policy.
I think the audience is eager to find out what they can do to help? For example, I have a question here that says, what are some of the most important things current medical students or those enrolling in medical school can do to help decrease the health disparities within the Latinx community? Dr. Bautista, Hayes-Bautista.
Okay, I get that asked that question a lot, and I will give the same answer I have been giving for the past 6 months. Whether you're a medical student, whether you're not, whether you're a worker, whether you're not, if you can, register and this November vote. And if for some reason you cannot register, find someone who is eligible to and get them to register and vote. That is the most important thing you can do.
All right, okay, yeah. There's a question that is addressed to Dr. Carlisle. The impact report for CDU testing for COVID-19 showed low testing for African Americans and other communities of color, with the majority of testing occurring among Latinx communities. Can you discuss audience target specific outreach efforts?
Well, I wasn't surprised by those numbers. I forget exactly what they are, but again, our report is on our website. I believe that, if I recall correctly, 86% of the tests that were administered were received by individuals who are Latinx. And if you know South Los Angeles, this is a community that 30 years ago was 90% African American. Today, by and large, it is about 70% Latinx. I think this is just a reflection of our community demographics, but it's also a little bit more also. When you think about maybe within that community, who may not have access to mainstream healthcare, who is very likely to be a younger population working in essential jobs. That is often members of the Latino community. So our numbers didn't surprise me at all, because those are the individuals that have the greatest challenge trying to access the healthcare system. Yes, we did have a number of African American individuals who received COVID-19 tests as well, and it was just it made me proud to see members of our university community, along with our other colleagues, typically people of color, providing services to a community that was almost entirely comprised of people of color. Those individuals felt comfortable coming to us because, again, we looked like them, we spoke their language, and they could trust us.
I think this question is relevant to this. What kind of training do medical professionals receive now on physician bias / cultural awareness or sensitivity? Is this required training right now?
Can I say something?
Of course.
It is so baked in to our educational system because it is baked into our research system that when it comes to communities of color, what is researched are basically stereotypes. And then that filters down into the educational system. So there are these stereotypes, for example, that people of color have their nerve endings further away from the skin so they can withstand more pain, so they don't need as much painkiller, blah, blah, blah. But even just the nature of who is a Black, when we say we have a Black person or a Latino in this randomized clinical trial, how do we make those classifications? Under what basis? What's the scientific basis for this? It starts at the top and it starts with research. Researchers, yes, the scientific method you could say is objective, but it's used by very subjective people who heard last night's news. They bring those attitudes into the research lab and they communicate them. That is why for me, it needs to start at the top. In the research laboratories, we need more researchers, not only of color, but who have found their voice, who are willing to raise their hands and say, wait a minute, that's only a supposition. Can you show me the data? I have data that say otherwise. Can we look at the data? And once we can start that within the research circle, that will start to filter out into the literature, then into the education, et cetera. So it's not just a question of is an individual faculty physician perhaps have implicit bias. We need to start at the top where there's the fountain, which is in the research laboratories.
Here's a question that it's very much in the news at the moment. Can you comment on police violence as part of this public health crisis? When cities like LA declare racism as a public health crisis following the recent riots, if we can call them that, will it have an effect on policy or practice?
You know, there's a shocking statistic, and I'm not sure that everyone is tracking it. It hasn't been very widely circulated. But whenever you hear people hear this, this is a ooh or ah kind of number. The 7th leading cause of death for Black men is death at the hands of law enforcement. That is profoundly amazing in terms of being a disappointing metric. The 7th leading cause of death. You know, we're talking about on the level of things like diabetes and motor vehicle accidents, death at the hands of law enforcement, being shot in the back, having your neck sat on or kneed for 8 minutes. This is incredible, but it is a public health reality for communities of color. Being down on your knees like the gentleman up in Vallejo was, with your hands above your head and still being shot to death. This is a reality in our communities, and it defines the environment of communities of color. And it is wrong without a doubt, and it impairs our life expectancy without a doubt. Think of all the years of productive life lost at the hands of law enforcement.
Okay. I think Dr. Loeza touched on this a little bit earlier about whether people will take the vaccine. And I think I take that to mean that there's a lot of anti-vaccine sentiment out there, and there's a lot of fake news. And it's not just on the right, it's on the left as well. You know, the health conscious people, natural yoga types. I have many friends that question the issue of vaccines. So what are some of the ways that you suggest communities and providers can encourage people to take the vaccine once we have one or more than one?
I feel like, you know, if you trust your medical provider, if you trust your clinician and you have access to one and you see them on a regular basis and you can have discussions and they've been there with you for a while and they've never really steered you wrong and they offer you a vaccine, you're more likely to take it. It's part of that relationship that you have. I mean, there's still going to be some people that are afraid and don't want it, but there's a lot of reasons why people don't trust doctors, and there's a lot of a history of experimentation of people of color. So I understand why people are afraid. And I always tell my patients that I get all my vaccines and that I give my child all his vaccines. And, you know, I asked one lady every time I saw her for 10 years to get a vaccine, and she finally did it. So it's just, but that's not going to be the norm, you know. So it's just, it's a very complicated issue. I think that we all at the clinic struggle with it and work really hard, and we really want our patients to get immunized. And we believe in vaccines, and we only want to do good. So it's very disheartening for us when we try to give a vaccine and people think we're trying to hurt them. So it's very complicated. I don't think I know the answer to that.
But honestly, it's more than a consciousness about history. Many people just believe stuff they read out there, like Bill Gates is going to put a chip in their brain with the vaccine or something. And this is a major problem. Don't you agree, doctors? I mean, what can you tell people about vaccines right now, people that are watching, that will help dispel some of this myth?
Well, this is a current issue with the influenza vaccine. The University of California just mandated influenza vaccination for all students, faculty, and staff. Our university is making it a requirement if you're going to come on our campus. We have a current issue with vaccination that extrapolates itself to COVID-19 vaccination. And I totally agree with Dr. Loeza. The most important thing, especially when you're dealing with distrust, is being somebody that a person can trust. Having that doctor-patient relationship that exists for years, having a nurse who is known in the community say, yes, flu vaccination is important. These relationships that occur in healthcare are important. And that's why it's important to have, again, this concordance between the providers, the nurses, the dentists, the pharmacists, and the communities they serve. That's why we want healthcare professionals to come from the communities where they're needed, because then their advice is much more meaningful and much more easily accepted.
Could I just, by the way, expand a little bit on something Dr. Carlisle has said? The importance of concordance is the importance of what we would call domain knowledge. What does this provider know about the community that this patient comes from? And let me give you an experiment everybody could do today, this morning. Go out and buy today's issue of the Los Angeles Times and read it. And if you do that every day, what do you know about Latinos? Well, you know that Latinos are gangbanging, illegal immigrant, teenage pregnant moms on welfare, because those are the stories that they run. That's what the average person that reads the LA Times every day knows about Latinos, including the physicians and the researchers. Then go out and read La Opinión. And it's like you enter a parallel universe where people are kind of normal, dealing with problems. And you have the businesses, and the soccer team wins, and the lost puppy gets found. And a provider that comes from reading La Opinión has that domain knowledge about the patients, whereas the one that comes from the domain knowledge of the LA Times has these stereotypes, and they put them into medical practice or into medical research. That's why the importance of understanding these different narratives. And this is not new. I can take you back to 1851 and show you a Spanish language newspaper published here in Los Angeles and the English language paper. And it's like the same thing, two parallel universes. They saw two different gold rushes.
Yeah, and having worked at La Opinión for 30 years, I know you're right. So, okay, we have a question here, and we're coming up to the end of the hour, but we still have a little bit of time. Have there been issues enrolling Black and Latinx communities in vaccine clinical trials? If so, how can we assure those communities that it is important that vaccine trials have broad representation so that we know that the vaccines are safe and effective in all communities?
Well, this is not only for vaccine trials, for randomized clinical trials in general. In fact, for what we're learning about the human genome, about 90% of what we know in Silicon Valley about computational genomics comes from basically Euro-American people that participate. We know very little about non-Euro-Americans around the world because we dominate the literature. So it's important to get good representation so that we can generalize out to other populations. But it's not unique to a vaccine. It's just because medicine, with its myopic view and its insistence that an organ is simply an organ, doesn't matter the life that that organ lives, to what that organ has been exposed to, the social networks, etc., and that the organ of an upper class white male in Boston can be generalized to the rest of the world. Some things, yes, a lot of things, no. That's why we need in medicine good representation, not only in the patients, in the providers, and most importantly, in the researchers.
Okay, we have a bunch of other questions here, but some of them are a little bit repetitive. I guess some people are looking for more solutions, you know, beyond recruiting doctors and nurses, beyond voting. What are you all doing to address the inherent racist practices within the medical care settings? And then someone else also asked, and I know this person, so I know she experienced this personally. She said, doctors are often dismissive about the needs of patients, particularly for people of color. How do we change medical gaslighting that is dismissive of patient needs? That's an intriguing question.
You know, I have to comment because it does start at the top. And one of the effective ways to make change is to change an organization from the top and to exert that change downward within the organization. There's something very common in medical education. That's the type of thing that we can change from the top. Every time a medical student, a resident, a fellow, another physician presents a patient, it's like the fifth word they say is automatically stereotypical. And it goes like this. It's part of our history and physical. It's part of our intrinsic training. An 85-year-old Black, an 85-year-old Latino, an 85-year-old Latina, an 85-year-old Chinese, man, woman, child, whatever. Why do we have to include somebody's race, ethnicity, color as part of the medical history and physical? But all medical students, nurses, dentists are trained this way. It is largely irrelevant, but it defines how we look at a patient. The fact that it is a fifth word in every history that we present about a patient. It is irrelevant at that point, but it tells people something that is not important about that person in our healthcare system. That's an example of the type of thing that we need to change from the top. Get rid of that. It's worse than unimportant. It is damaging because everything else seems to follow from that labeling. And let's get rid of it. It can go somewhere else in the history where it's much more important. That's just an example of change from the top. Let's get rid of that from medical education.
Okay, so we're getting ready to close. And before we do, I want to give each of you a chance to have some last famous words for today. Dr. Carlisle, anything before you go?
Well, you know, I was sitting here reflecting, and I just want to say, you know, how proud I am of my colleagues, Dr. Loeza, Dr. Hayes-Bautista. You know, these individuals are in the trenches every day, doing the right thing, making a difference. And there are many more people like them. And I'm just proud to say that it's a pleasure, an honor, and a privilege to work with you because you're making a difference.
Thank you.
Dr. Hayes-Bautista?
Well, in fact, I'd like to let people know about a book that a number of us written about the 50-year history of the community clinics such as Venice. This is it, if you can see it, called The Chicano Boom, Healing California, going back 50, because a lot of clinics like La Clínica de la Raza, Venice, Ultimate, others are celebrating their 50th anniversary. We have the 50th anniversary of the Chicano Moratorium. And most people say, but the Chicano movement ended about 1974. And with this book, we have interviewed about 200 veteranos. The clinics are still here providing service. What do you mean it ended in 1974? These movements are still alive and well today and are the centers for health and strength in our communities.
All right, muchas gracias. Dr. Loeza?
Well, I guess, I mean, I know we already said this and people feel like it's not enough, but I want everyone to vote and I want everyone to complete the census so that they're counted and we get the appropriate representation. And I want everyone to send Venice Family Clinic money so that we can keep doing our work. So a horrible plug, but we need to stay open. We are doing, you know, my colleagues are coming to work every day, even though I know that they may be scared that they're going to get infected and bring it home. But the people at the clinic are showing up, working hard and keeping it open. And it's been amazing to see what everybody's done.
Well, thank you everyone for being here. Thank you to our distinguished panel. And thank you for attending Venice Family Clinic Health and Justice event series. And you can make donations at the link in the chat. Thank you for having been with us during this hour.